Uh, I hope most of you, I almost see many familiar names. So most of you know me, but for those who don't, my name is Tamour Tareen. I'm one of the PGY-4 Neurology residents and here to present my grant rounds today. The topic that I'm going to talk about is PFO Enigma and strokes. Looking back at why I chose this topic, so during our residency training, there were several instances where I look back and try to find out the prevalence, incidence, and the mortality associated with the PFO and strokes. And I'm glad that I'm talking about this because there will be several major considerations which we all will learn as we move across the presentation. So coming to strokes, a quick recap. How bad and big is the problem? So it's the third leading cause of death and the leading cause of disability in the United States. The yearly incidence of stroke in US is 650 to 700,000 per year. Of these, 10 to 40% are cryptogenic. What I mean by cryptogenic is that we never find an etiology, we never find a source for the stroke. We'll dig into those details more as we go along the presentation. Assuming PFO being a cause of the cryptogenic strokes, since it is present in 33% of cryptogenic stroke patients, approximately 21 to 90,000 strokes per year can be attributable to PFO. As we all see, that's a very significant number of patients. Patent foramen ovale, or as I call it, potential for opening. So what is it? As we all know from our basic sciences, during fetal development, the foramen ovale is an opening present between the right and left side of the heart, which normally closes during infancy. However, if this is not closed and it persists, then this foramen ovale beyond the infancy is called a patent foramen ovale. In addition to our talk on strokes, it is also important to mention that PFO has also been implicated in strokes, migraine headaches, deep sea diving, orthodexia or platypnea, sleep apnea, and liver transplant. So it's not just strokes that is one of the neurological manifestations, but it has also been implicated in some cases of migraines. So why do we need this PFO talk? I think the PFO prevalence in general population is quite high. That means the foramen ovale persists in almost 25% of the adult population, but we never find it out until we test for it. Additionally, it is also an important cause of strokes in younger population. Given the fact that those younger population, with intervention, we can reduce the risk of recurrent stroke, we need to know and learn more about the PFO and also have a non-distorted view and be clear in mind what do we mean when we talk about PFO, cryptogenic stroke, recurrence of strokes, and the treatment options. Before digging into the topic itself, I would like to briefly talk about stroke itself and what are the different types of strokes. So the two major categories are ischemic stroke and hemorrhagic stroke, with the ischemic being much more common with a 83% distribution, whereas hemorrhagic is 17%. And when we dig into the details of ischemic stroke itself, we see that we have divided into 5 different etiologies which can cause ischemic strokes. This includes atherothrombotic cerebral vascular disease, lacunar or small vessel disease, cardioembolic, other which do not fit the above criteria but have some other known etiologies such as vasculitis, dissection, or hypercoagulable disorders. So any of stroke which does not have any of these 4 etiologies, we end up calling it cryptogenic. And as for hemorrhagic strokes, which would not be the focus of our discussion today, it can be divided into intracerebral hemorrhage and subarachnoid hemorrhage. So we review these one by one and see that how is cryptogenic different from each other and how PFO plays a role. So firstly, we talk about large vessel atherosclerotic stroke. So atherosclerotic cerebrovascular disease results in stroke when there is an important impediment to normal blood flow or perfusion as a result of severe large artery stenosis or occlusion due to atherosclerosis and coexisting thrombosis. From our neurological experience, we all know that there are some regions, the head and neck, which are more prone to atherosclerosis, and there are some which are less common. The more commons are the bifurcation and siphon portion of common carotid artery, the stem of the middle cerebral, and the intervertebral arteries and their origin. The less common are the origin of the common carotid, posterior cerebral artery, origin of the major branches of the basilovertebral arteries, and the origin of the other major cerebral arteries. So with the stroke and evidence of atherosclerosis, we feel comfortable now to call it a large vessel atherosclerotic stroke. The second important strokes or lacunar infarcts are also called small vessel disease. These are small 0.2 to 15 millimeter in diameter, non-cortical infarcts caused by occlusion of a single penetrating branch of a large cerebral artery. It's important to know that most of these branch at acute angle from the large artery. Lacunar infarcts result from microatheroma, lipohyalinosis, and other occlusive diseases of the small penetrating arteries of the brain. We also end up sometimes calling them as subcortical infarcts. In some relatively uncommon cases, tiny emboli have also been suspected as the cause of these small infarcts, but these are much less common than the other etiologies discussed above. Next on the etiology list comes cardioembolic sources. So a cerebral embolism is a result of a clot or embolus that forms in another portion of body, such as the heart, and is carried through the bloodstream, then becomes lodged in an artery that supplies blood to the brain and blocks the flow of blood. Examples include major arrhythmias, as detailed on the slide, structural defects, or impaired function of the heart. Any impairment in the heart function, structural disease, reduced ejection fraction, blood stasis, or any other abnormality can be the culprit for a cardioembolic source to cause a stroke. So we previously discussed the high-risk cardioembolic sources. Now we talk about the low or uncertain risk cardioembolic sources. We see the first one on the list is PFO or patent foramen ovale. And mostly in our workup in stroke, it is a diagnosis of exclusion. In addition to this, there are other common cardiological abnormalities which can also cause cardioembolic strokes, which includes atrial septal aneurysm, annular calcification, or any structural or CHF that causes akinesis of the heart wall. When we've ruled out all the major etiologies that can cause stroke, our focus is next to look for other less common etiologies and make sure that they are not causing the stroke or contributing to its pathophysiology. Some of the most important and notable ones are dissection of the arteries, major arteries of the head and neck, Moya-Moya disease, Binswanger disease, primary thrombosis, or cerebral masses. Most of these, except primary thrombosis, do not require very specialized workup, as we all know. During the routine workup of the stroke on imaging, we discover them if they are present. But at this point, we have ruled out all the major etiologies of stroke. And this leaves us with cryptogenic stroke. So what is a cryptogenic stroke? Any stroke that does not fit any of the above discussed etiologies? That would be right to say so, I think. Additionally, there should be no large vessel stenosis or occlusion in the territory that is responsible for the infarct. There should also be no evidence of AFib or other high-risk cardioembolic source, and no clinical lacunar stroke syndrome if the imaging is negative or if there's a small infarct. In addition to satisfying all these three criteria, we also have to rule out the other possible etiologies, which we discussed in the others in my last slide. Revealing the figures and statistics, it's interesting to know that approximately 10 to 25% of all ischemic strokes are cryptogenic. Of these ischemic strokes, 34 to 46% occur between 18 to 60 years. And PFO is present in 40 to 50% of cryptogenic stroke patients. So I guess it's safe to say that PFO is present in almost half of cryptogenic stroke patients. Coming to cryptogenic strokes and PFO, like I said, PFO is very prevalent in the population with cryptogenic strokes. Almost 50% or every second patient with a cryptogenic stroke per statistics does have a patent foramen oil. Some important considerations are that thromboembolism is much more commonly fatal in this population if present. Also, PFO prevalence decreases with age. Another important statistics is that PFO is seen in 45% of travelers with stroke. So we keep on talking about stroke and PFOs. And why I'm emphasizing this fact again and again is because an untreated PFO or patent foramen oval has a risk of recurrence of stroke if wrongly diagnosed and mistreating the primary etiology. It is important to note that the national cost of recurrent stroke requiring hospitalization and lost work days is enormous. This only does not include hospitalization, but also the disability that comes with it. It is also very important to note that since cryptogenic strokes and PFO are prevalent in the younger population, we are risking the younger population to recurrent ischemic strokes. Just a quick figure to present that how much are the treatment costs. So a transcatheter closure, one of the options for PFO closure is about 30,000 a case, whereas a surgical closure is 45,000 a case. Surgical closures are rarely needed until structural abnormalities or other abnormalities are present. So we'll try and understand better that what is a patent foramen ovale, which I also call potential for opening. So basically, it is a lack of opposition between septum secundum and septum primum, which are two layers in the formation of the interatrial septum between the left and right side during the embryological development. PFO, or a potential for overlap, it also has a potential for being onerous. And we'll see in details that which conditions makes it high risk or onerous. Going back to our basics and a quick look at the Pfo embryology. So during fetal development at week 4 of pregnancy, development of the interatrial wall between the left and the right atria starts. To begin, as shown in the figure, which we all can see in A, initially from the top or the atrial roof, the septum primum grows toward the endocardial cushions, which are at the inferior portion or at the atrioventricular junction. These endocardial cushions grow toward each other, fusing, and then divide the AV canal into the right and left sides. This creates foramen primum. As the foramen primum now continues to grow toward the endocardial cushions, perforations then develop in this septum primum. Ensuing, these perforations then fuse, forming the foramen secundum, which allows the oxygenated blood to flow from the right to the left atrium. Next in the process, the foramen primum closes. Soon after this, as seen in figure D, a second membrane, the septum secundum, grows from the right side of the septum primum. The septum secundum then overlaps part of foramen secundum, forming an incomplete septal partition that becomes the foramen ovale. The remaining part of septum primum is now acting as a flap and acts like a flap-like valve over the foramen ovale. So the foramen ovale and flap-like valve provides shunt between the right and left atrium, which supplies oxygenated blood from the inferior vena cava, which is shunted through this ovale, foramen ovale, into the left atrium. In this process, with the shunt, the blood circumvents the non-inflated lungs. However, after birth, the filling alveoli causes pulmonary arterioles to open, which causes reduced right heart pressure and pulmonary vascular resistance. Both the reduced heart pressure, reduced pulmonary vascular resistance, and the increasing amount of blood returning from the pulmonary circulation raised the left atrial pressure. As the left atrial pressure raises, this flap is now closed and the communication is now shut, which is the normal phenomena for most of the infants. However, in approximately 25% of adults, this does not happen and it remains patent. There are some considerations and there have been some investigations to see that why some infants outgrowing into adults still have a patent foramen ovale, and some familial and genetic factors have been accounted for this. One study compared 62 patients and found increased prevalence among female siblings, giving us a point that it could be genetic. After this, we now discuss the diagnosis of PFO, especially in workup of stroke. So transthoracic echocardiography bubble study is commonly used for diagnosis of PFO. The bubble study, in addition to TTE bubble study, TE bubble study is currently the gold standard for PFO investigation with 89% sensitivity and a 91% specificity versus confirmation by several different mechanisms that includes autopsy, surgery, and or right heart cath. The presence of PFO is determined by agitated saline bubbles that shunt into the left atrium and are recorded within 3 cardiac cycles. Recently, transcranial Doppler for cerebral blood flow has also been used as a screening tool for detection of right to left shunt. TCD has a greater sensitivity and accuracy, but however is less specific than transthoracic and transesophageal echogram for detection of PFO in cryptogenic stroke. That's why it is still not very common in use. Also, it carries a low specificity where it diagnoses not PFA per se, but also the right lung shunt, right to left shunt, more importantly. We always see on reports different variations and comments on PFO. So PFO can be divided according to its width, with large being 4, medium being 2 to 3.9, and small being less than 2 millimeters. Circling back to our discussion. So in young stroke patients less than 60 years with no etiology for the cerebrovascular event or stroke, with the diagnosis of a cryptogenic stroke, prevalence of PFO is almost 30 to 55%. It's interesting that through 2016, no randomized control trial had reported long-term outcomes for PFO closure. This brings us to the fact to look at the evidence for PFO closure and the different trials. Highlighted are the 6 different trials that have happened to date. The first one, called Closure 1, was conducted in 2012. It had 909 subjects. It included patients broadly with cryptogenic stroke, and there was no selection criteria used. It showed a tendency for reduced stroke, but that was not statistically significant. Also, there was a major chunk of patients that had periprocedural vascular adverse events and high rate of AFib. The next trial was the PC randomized clinical trial that was conducted in 2013. This also failed, showing no decrease in the risk of death, and also reinforced the previous concerns that we had that a non-significant increase of AFib was recorded with the PFO closure as compared to the medical arm, treatment with medical arm. The RESPECT trial was published in 2013. It is one of the longest trials. It is important to know that the initial results of RESPECT were published in 2013 with a review of long-term outcomes in 2017. The initial trial's results were mixed, and it did not provide any guideline or failed to change any treatment guidelines. So the first 3 meta-analyses did not show any significant results in favor for the closure group. But then came the RESPECT extended review. This trial compared the Emplazer PFO occluder versus medical therapy. To date, this has been the longest follow-up trial and also with the largest number of patients being enrolled. It is important to know that it showed a significant increase in recurrent stroke with PFO closure, 3.6% versus medical therapy alone, 5.8%. The number needed to treat to prevent one stroke in 5 years was 42 patients. This was also the first trial which not only evaluated stroke patients, but also looked at different PFO variants that included shunt size and also its variation or atrial septal aneurysm. And it still favored PFO closure, 2% versus medical therapy alone, 4.2%, showing that there was an increased risk of recurrence of stroke in the medical therapy alone group. This figure is a presentation of the Kepler-Meyer curve comparing the long-term outcomes between the two groups. And we see that after the 5 to 6 years window, the medical group has worse outcomes as compared to the PFO closure group. And this definitely explains why the medical group initially did not yield good results. RESPECT trial led to the first FDA approval for a PFO closure device. Since then, several trials have happened. These include the reduced randomized trial. The difference in these trials was that every time the inclusion criteria was more stringent and included patients with high risk, and all of these showed significant decrease in recurrent clinical ischemic stroke, whether it's the reduced trial, whether it's the closed trial, or whether it's the Defense Pro trial. So as we move on, we see that in Defense Pro trial, which was conducted in 2018, it included patients with not only cryptogenic stroke, plus high-risk PFO features. So by this time, we have now learned more about PFO, its morphology, and its high-risk features. This is to date all the randomized controlled trials on PFO closure, which we briefly discussed. It's also important to know that two different devices were tried. One of them was the Emplatzer PFO occluder, and the other one was Starflex. To date, evidence-based data from all the 6 different trials we have, let's talk about that. Meta-analysis of all these trials happened to date shows that 37 strokes happened out of the 1,889 patients that underwent PFO closure group versus 79 in the control group with a relative risk of 0.36. And the number needed to treat was 131 to prevent one recurrent stroke. Despite the moderate absolute risk reduction, the benefit could be clinically significant in long term, and this is what exactly we saw in the RESPECT extended trial. That the patients with PFO closure group have better outcomes in the long term. Again, a systematic review and meta-analysis of all PFO closure groups have shown that risk reduction was more pronounced in patients with high-risk PFO, that includes atrial septal aneurysm, and in patients with this higher risk of anatomical features, the PFO closure was 0.27, while there was a non-significant trend in patients with lower risk anatomical features. So what we have learned over time is we can now categorize PFO into high risk, having features that are more susceptible to paradoxical embolism and can contribute to the stroke, providing us a better guideline of who to treat and who to not. Responding to all of this data, the AAN guideline update was issued in 2020, back in May. And it did agree that patients with cryptogenic stroke and PFO, percutaneous PFO closure probably reduces the risk of stroke recurrence. However, it also discussed the complications coming with it, which included pre-procedural complication and non-peri-procedural atrial fibrillation. Fortunately, the practice advisory updates also gave us some guideline and interpretation of data which we as neurologists can more comfortably rely on the different patient populations and what are their long-term outcomes with all these closure devices. It showed positive results in all of these groups. For instance, patients with more than 60 years and no other morphology, closure reduces the risk of recurrent stroke. We all previously knew that it has a small risk of procedural complications, but overall, for eligible candidates, it was shown superior as compared to the medical group. So now we have mounting data over time that in the right patients, in the right patient group, identifying the right patient population, identifying the right risk factors, PFO closure groups has much better or twice better long-term outcomes as compared to the medical group. And this, I'm glad to see that these trials, more and more of these trials are happening with future research focusing not only on younger population, but also on older population and those without high-risk PFOs. Currently, there are 4 studies going, which are listed below. So now the big million-dollar question: who gets a closure? Which patient with suspected cryptogenic stroke and PFO? Who qualifies for a closure? Some important considerations that we need to make before we move on to qualify these patients as cryptogenic stroke. First, symptoms must last for more than 24 hours and must be relating on imaging with what we see clinically. Is there an embolic stroke on imaging? And we all know that there are some different characteristics of embolic strokes on MRI or other imaging that includes multiple vascular territories or a wedge-shaped infarct. Thankfully, with the ROPE study base or the risk of paradoxical embolism study database, we were able to identify the higher prevalence of PFO with cryptogenic strokes, which included large index strokes actually seen on imaging, and superficial cortical location. So now we are pretty much confident that we have a patient with embolic appearing cryptogenic ischemic stroke. But still, we need to do thorough evaluation to rule out other etiologies, including cardioembolism, large vessel atherosclerosis, and all the other potential possible mechanism for the stroke. It's very important to exclude atrial fibrillation. Unexplained stroke in the setting of AFib, I would say occult AFib or aflutter, would suggest an association between the two and mandates chronic anticoagulation. It's also important to know that Prolonged cardiac monitoring has identified AFib in 16% of patients with cryptogenic strokes. And we all know these patients would never be candidates for closure. This is a busy slide, but it basically looks at all the possible etiologies that we have to look and rule out conclusively before going on to a closure device. So next, if everything is negative, now it's time to obtain an echo and look for that PFO, which we've been talking about. Before discussing the further management, with time, with all these randomized controlled trials, and with all these studies, we have learned that which special characteristic features on echo findings are high risk and are more related with PFO causing the cryptogenic stroke. These involve increased septal mobility, which mechanically directs blood from the inferior vena cava into PFO, increasing the risk of embolism. A long tunnel, atrial septal aneurysm, thick septum, large versus small PFO, multiple orifices in the left atrium, and some other variants. Next step would be grading of PFO and echo. So we all keep reading about these reports which shows the number of bubbles whenever we order TE or an echocardiogram. So how we grade is that it depends on how many bubbles do we see in the left atrium spontaneously or after provocative, which could be a Valsalva maneuver within 3 cardiac cycles after opacification of the right atrium. According to that, we grade it with the grade 3 or large, the highest grade, which shows more than 25 microbubbles. So now we have results of echo with silent study. If there is no PFO, pretty simple. We don't have any other etiology for anticoagulation, so we stick with antiplatelet therapy. But if the PFO shows a positive bubble study, what's next? For patients with positive bubble study, we have to do a thorough workup for venous thromboembolism. This is important since it changes the management and course of our treatment. Finite versus prolonged anticoagulation holds off the procedure of closure of PFO. So it's very important to rule out and do a very thorough workup for the venous thromboembolism. After ruling out venous thromboembolism, the next question is, what is the age of patient? And it's pretty simple at this point. If the patient is 60 plus, we recommend antiplatelet therapy. And if it's somewhere between 18 to 60, PFO device closure with antiplatelet therapy is recommended. There are some very important clinical bedside techniques or history tips which can also help us. For example, what was the patient doing before the stroke happened? Was he doing something that could increase the right to left shunt? Maneuvers like straining, cuffing vigorously. And was there any risk for DVT, such as prolonged immobility, dehydration, or hypercoagulability? This slide talks about features that increase the probability that PFO is the cause of stroke. And I think we have discussed most of these. It's just a reminder for us. Again, this slide repeatedly reinforces the role of or excluding that DVT or venous thromboembolism was not the cause of stroke. This strengthens the clinical inference of paradoxical embolism with important implications for therapy. And it's important to know for us as neurologists that ideally the evaluation should be done within 2 to 3 days of stroke onset. In the past, and from my clinical experience, and this was a good learning point, studies including radiography or MRV in patients with ischemic cerebral events have been negative or have variable rates. But the possible explanations for these are that either the study was not done at an appropriate time, the clot lysed, or the both upper and lower extremities were not tested. In some cases, it can also be attributed to the IV thrombolytic that we have given for the acute stroke. Finally, after ruling out all these possible etiologies, a heart-brain team fosters a shared decision, which includes a neurologist and a cardiologist to ensure proper patient selection. This approach basically prevents the use of unnecessary closure devices being used. We'll talk in the end about a very important tool we as clinicians, as neurologists can use and are using to evaluate that how much is the PFO being attributed to the cryptogenic stroke. The ROPE score was created in 2013 with the aim to have an index to stratify cryptogenic stroke with PFO by their likelihood that the stroke was related to PFO. It estimates the probability that PFO is the cause of stroke in a cryptogenic stroke. A high score suggests that stroke is most likely related to PFO. In this next slide, we see that in the ROPE score, from our previous experience and based on data results, this was designed in a way that patients with young age have the highest score. So if someone is between 60 to 69, he just gets a 1 score out of 5. That means this score is age dependent and automatically favors patients with young patients for device closure. Other important things which we look are for typical vascular risk factors and the type of stroke we see on imaging. So maximum score is 10, who is less than 30 years, no hypertension, diabetes, or other stroke risk factors. And a maximum and a least score is 0 for a patient of 70 years with all the vascular risk factors, in which there is a 0% chance, almost a 0% chance, that the PFO actually did cause the stroke. This chart shows data from a recent study which shows stroke from PFO and recurrence rate of stroke/TIA at 2 years. And as we see, as the ROPE score increases, the PFO attributable stroke fraction increases, whereas the estimated 2-year stroke TIA risk decreases. And this is because the PFO recurrent strokes are much less common as compared to the strokes caused by non-PFO etiologies, as they are much more common in the population. Unfortunately, ROPE score is still not validated for selecting patients who might benefit from closure, but it is still a good tool for us to support the decision to proceed with PFO closure in patients with very high ROPE scores or decline PFO closure. Three most important, or the three factors it looks at, is age, absence or presence of vascular risk factors, and the type of lesion that is located on MRI. So now we can easily conclude that Patients who have a documented cryptogenic stroke from a presumed paradoxical embolism should get a PFO closure. Interestingly, I share a snapshot of a recently published article in JAMA Neurology, where a group of cardiologists and some neurologists proposed that there should be an updated nomenclature for classification of potential causative mechanism in PFO-associated stroke. The push from cardiology and other fields is to now call it a PFO-associated stroke and not a cryptogenic stroke. Whether this happens or not, we'll see in the future, but it also depends on the long-term outcomes of these trials. And I don't think it's far away because we are already 7 or 8 years that we started using these devices. And once we cross the 10-year mark, we'll have much better results and clear view. Just a quick snapshot of the different closure devices. So the first closure devices were cleared by FDA in 2002. Unfortunately, they were shortly withdrawn after their excessive use, whereas they were allowed for only 4,000 cases. The most important one, or the clinically significant, is the Amplatzer PFO occluder, which was approved in 2016 and is still in use. And in 2018, with the increasing trials and increasing evidence, a second PFO closure device was approved. A quick look at what the PFO Amplatzer PFO occluder looks like. So it's basically, the video needs some time. So it's basically a self-expandable double disc device with one disc attaching on each side of the atria, on the interatrial septum. And it is lined with polyester fabric and linked together by a short connecting waist. Can be used via transcatheter approach, as I mentioned. Just a quick snapshot of the different devices approved by USA, FDA for use in PFO closure. These include the Amplatzer PFO occluder and cardioform septal occluder. Both of these are percutaneous transcatheter and will be re-reviewed in July 2021. That's just next month. Quickly looking at the history of how these devices evolved over time. So coming back to the most important slide of the presentation, takeaway point, who should be offered a PFO closure? Patient who is 60 or more years with an embolic appearing infarct and no other mechanism of stroke on extended workup. And this is the fact that I want to reinforce, point number 2. Presence of large atrial shunt and or atrial septal aneurysm. As we discussed about this point, that now we need to pay more attention to the high risk echo findings when we review reports, since it's our job to refer someone for a closure intervention, as cardiology would not intervene until we request them. And identifying these two high risk associations of PFO with stroke. So in 60 to 65, there's a little bit of change. There should be none or limited degree of traditional risk factors and no other mechanism of stroke, including AFib. And most importantly, for patients less than 30 years, with a single small deep stroke, a large shunt, and absence of any vascular risk factors that could lead to intrinsic small vessel disease. So all these 4 patient population groups should be offered a PFO closure. And lastly, The decision for PFO closure should be a multi-team approach. This is not only necessitated by the FDA approval, but also has medical ethics involved. It should be discussed between the cardiologist, neurologist, and of course the patient to explain the different trials, their outcomes, and which specific attributes the patient has that favors, based on the data of randomized control trial, that he or she should get the PFO closure. There should also be a thorough discussion about the risk of stroke recurrence and risk of adverse events. And with this, ladies and gentlemen, I come to the end of my presentation. I would be glad to take any questions. Hello. Hello.
Hey, Tareen, I think, we are still here. We hear you.
Okay, sorry, I just switched windows. So, yes. Any questions, anyone?
Very good presentation, Tareen. Good job.
Thank you.